Hey everybody, let's get started here. We got chapter 19 to do, the respiratory emergencies, as we talked about in class. The beginning of these chapters with the specific emergencies, with specific body systems, beginning of those chapters is going to be a little bit of review of the anatomy, some of the anatomy and some of the physiology there. So we should be all caught up on that. And so for this video, I'm not really going to be spending a lot of time on that review stuff. If in your reading you're uncertain of anything, just check in the beginning of the chapter. It lets you know what chapters are related to this, and you can go back and refresh your memory if you're not certain on some things. So I'll be moving quickly through some of that stuff. So let's get started here. All right. Let's see. Let's talk about adequate breathing real quick. Let me just touch on that. Adequate breathing is, let's start with the definition. First of all, adequate breathing is, it's enough to sustain life. It's enough to keep somebody alive. What we're all doing right now is adequate. It's keeping us alive, hopefully, right? And some signs of that is normal mental status, speaking in full sentences, work of breathing is easy, it's quiet, they have good color, oxygen saturation, things like that are normal. Um, for adequate breathing, what we do need to know are these rates. We need to know these. So make sure that you are comfortable with these rates. We've got to know the adults are 12 to 20 breaths per minute. School aged kid is 18 to 30, and then 30 to 60 for an infant. Should be regular as far as the rhythm goes, and breath sounds should be equal and present. We should just hear that air whooshing in and out without any sounds of obstructions in there. Now, again, as when we talk about normal rates for things, ranges for these things, context matters. So this is when your patient is at rest, all right? When they're at rest. So please know those. To touch on inadequate breathing, it's too fast. It's too fast or too slow. Just by definition, inadequate breathing means that it's not enough to sustain life. So it's either too fast, it's too slow, the tidal volume is too poor, things like that. They're not bringing in enough air, basically. Some signs of this could have altered mental statuses. Again, the breathing could be too fast or too slow outside of those normal ranges. The work of breathing could be increased and obvious. We'll talk about some signs of that in a second. Their ability to speak could be hampered, so they may only be saying 1 to 2 word sentences, 2, 3 word sentences, real choppy, short and choppy sentences. And they could have a silent chest, which is a real bad sign. It means you're not hearing any air move through there. So if they have a silent chest, that's obviously a big problem, and it very much speaks to the inadequacy of their breathing. Low oxygen saturation, despite giving them supplemental oxygen, that can be a sign there that their breathing is inadequate. Agonal respirations, we talked about those. This is basically the body's last attempt at getting air in. Somebody can be completely unresponsive in cardiac arrest, and you'll hear, or you may see some of these agonal respirations. It's just like gasping. It's just something like that, but they may be really spaced apart. Maybe it's 10 seconds apart, maybe it's 20 seconds apart, something like that. When you see that, it's not considered breathing. If we remember back to our CPR, agonal respirations are not considered normal breathing. So if you see that, just note it that it's agonal, but just treat them as if they're not breathing. Diminished or absent lung sounds are bad signs for the breathing that can show inadequacy. And then obviously poor tidal volume, right? If they're taking very short, shallow breaths, that could be an obvious sign there of poor tidal volume, not getting enough air in. We know about the pediatric notes for the A and P, so please make sure you know the differences between pediatric anatomy and like an adult's anatomy as far as their respiratory system goes. Some signs of inadequacy for kids include nasal flaring, grunting, they're working hard to breathe, seesaw breathing, right? And retractions, where we can see muscles up around the collarbones being kind of sucked into the body there and in the intercostal spaces a bit. That just shows the body's using everything they got to breathe. It's a sign that they're working way too hard to breathe. And when you get that sign, that's showing because the body's using those muscles, the regular muscles that they happen to be using at that time are getting more tired. So the body's using everything it can to get some breaths in there. So not a good sign. All right, for patient care for inadequate breathing. All right, a couple examples here. For test taking purposes, because two questions usually show up on National Registry, um, um, or they happen to show up a lot. I don't know if it's going to be every time, but one of the questions is, which is the most effective way for one rescuer to provide ventilations to a patient? And the answer is it's going to be the pocket mask with supplemental oxygen. So you got the pocket mask and you hook it up on there. And I'm sure the reason is easy for everybody to see, but it's because you can get a good seal with the pocket mask and take care of your head tilt chin lift and deliver the breaths all by yourself, right? You're only holding that one little thing there. So it makes it easier there. The best way for two rescuers to give assisted ventilations there is with a bag valve mask with supplemental oxygen. One person can get the seal, take care of the airway maneuver. The other person can take care of just squeezing the bag. And then the last is going to be the one rescuer bag valve mask with supplemental oxygen. Obviously, it's a little bit more difficult, as we found out when we did this in class. We've got to get the seal with one hand and then working the bag with the other. Your seal hand's also busy trying to get the airway maneuver done as well. So it makes it a little bit more difficult. So that's the test. Now, in my experience, right, this is my experience. In all my years, I have not seen a pocket mask being used out in the wild. I've not seen one. And this is riding with a bunch of different companies and everything else. It's usually in the real world, again, to my experience, it's going for the bag valve mask first. We should be really comfortable with the bag valve mask because of this and how it works. And so maintaining your discipline when doing it and staying on top of your skills is really important. All right, so when we are providing assisted ventilations, we know this. Also, these rates, we need to know these rates. So for adults, we're going to be breathing for them 10 to 12 breaths per minute. That means once every 5 to 6 seconds, we're going to give a breath. For kids, it's every 12 to 20 breaths per minute, which means that's going to be a breath once every 3 to 5 seconds. Obviously, kids, as we know, with their vital signs, their rates for respirations, they breathe a little bit faster than adults do. And so that's why we're going to be breathing faster for them. So we've got to know these rates. 10 to 12 per minute for adults. It's once every 5 to 6 seconds. Right? 1, 2, 3, 4, 5, squeeze. 1, 2, 3, 4, 5, squeeze. And then for kids, it's 12 to 20 breaths per minute. So it's once every 3 to 5 seconds. So 1, 2, 3, squeeze. 1, 2, 3, squeeze. You could make it easier on yourself and just do it every 5 seconds for everybody because that fits in the range there. But you may need to breathe a little bit faster for the kids. So you may need to up that a little bit. Just be aware of that. So know those rates there. There are problems that we can have, as we talked about with in our visual ventilation chapter, with ventilating somebody. If we're doing a poor job, right, the body is still going to be compensating for things, despite the fact that we're working and we're trying to give breaths with the BVM. The body's still going to be trying to compensate. It's figuring out what's going on and trying to stay in that nice homeostasis area there, right? That Goldilocks zone where everything's just right. So there's going to be compensation. If we're doing a poor job ventilating, we're going to see signs of that in adults. And we're going to see the pulse rate rise. So one of the things that you can do to make your life a little bit easier is when you're ventilating somebody, have that pulse ox on them, just like maybe throw it in their lap so you can see it, right? And just keep an eye on that pulse rate. You can see it in real time how you're doing. And if you're seeing it climbing, well, maybe we're not doing a great job ventilating there. So, check your seal, redo your airway maneuver, make sure we're getting breaths into the chest, confirm that with that chest rise and fall. Maybe have a partner auscultate the chest so we can hear air whooshing in and out, things like that. Kids are a little bit different. Their pulse rate's going to fall. They're much more susceptible to poor things happening with a lack of oxygen. So if we're not ventilating them well, their heart rates are going to go down. So again, same thing, put the pulse ox on so we can watch that pulse in real time as we're doing it. So if we're seeing that pulse rate drop, then we need to reset what we're doing, right? Make sure we get a good seal, reset the airway, confirm that we're getting breaths into the chest by looking for chest rise and fall, looking for any coloration to come back in the skin, listening, auscultating to the chest, having a partner do that while we're giving a breath so we can hear that air whooshing in and out. Right? All right, breathing difficulty. We talked about this a little bit. This is subjective to the patient. So you may come upon somebody where they don't look or everything on your vital signs and on your monitor and everything's looking good for them, and they're saying, I can't breathe. We got to take them at their word on this, because the amount of distress they're feeling is subjective, and it's going to be different for everybody else. Maybe somebody's really cool, calm, and collected and is in a really, really bad spot, right? Or maybe, somebody's not in a really bad spot and they're very anxious about it, right? So their level of anxiety or distress over whatever the situation is there may not reflect the actual severity of the condition. So just keep that in mind. This is a really easy place for people that are experiencing burnout. This is a very easy trap for them to fall in. And unfortunately, I've seen it out there where somebody's having difficulty breathing and somebody's just looking at the monitor saying, well, your pulse is good, your O2 sats are good, your CO2 is good. You're fine, just kind of, calm down. That doesn't really work, and that's not really the best way to approach things. As we learned about giving oxygen, we never withhold it from somebody that needs it. So, and then we've talked about also, when you move up levels, certification levels, to your paramedic or your nurses or your doctors, we got to treat the patient and not the monitor. We can't get lost in the numbers on the monitor. We got to treat the patient. So it takes a lot on our end. Okay, we got to consider what's in front of us with the patient and how they're feeling, right? And that's subjective to them. And then also we got to take into consideration what we're seeing as far as what's on the monitor, or what's in our vital signs, and things like that. All right. Like I said, give them the benefit of the doubt, even when all signs are pointing to them in your mind, like, you shouldn't be having trouble breathing here. But just believe them. Just believe them. Okay. OPQRST, we know all those. Let's talk about some observations, how we can observe breathing difficulty and what we may see. As we talked about with our 4 of spades hypoxia guy, right? 4 of spades. One of the first things to come about when somebody gets starting to get hypoxic is we're going to start to see mental status changes. So we can have altered mental status when somebody's having breathing difficulty, especially if it's inadequate. They can have unusual anatomy, the barrel chest. We read about that. Patient's positioning. We've talked about that. You don't tripod unless you're having difficulty breathing, right? It's clear sign. And when we see it, and we're using our pattern recognition for some things to try to get us on the right path towards a diagnosis there, this tells us, like, when we see that guy, that's trouble breathing. That's trouble breathing right there. We don't even have to talk to somebody when we see that to figure out that they're compensating for their inability to breathe well at that moment. So tripod, we can always say that's a sign of difficulty breathing. The work of breathing, it could be really labored. They could be working hard to breathe. As we know, normal breathing is it's easy, it's quiet. You don't have to work real hard for it. So worker breathing, we can look for signs of retractions and the use of accessory muscles, flared nostrils, pursed lips, doing anything the body can to just get more air in. Number of words, again, choppy, short, choppy sentences. We've talked about this a whole bunch of times. They're another good sign. Skin color, they can be pale, they can be cyanotic, they might be a little bit flushed. We can have pedal edema, which is going to be that excess fluid that's swelling down in the dependent parts of the body, the gravity dependent parts down there. So pedal edema is basically below the knees. We can see that. Sacral edema, this is going to be for somebody that's been sitting or is bedridden. That edema is going to be kind of down in their lower back, down there for that. And then we can have oxygen saturation problems as well, like as a sign that they're having breathing difficulties. So anything less than 95%, we're getting into that hypoxic zone there. This is a great picture of a gentleman that's having breathing difficulty. We can see right away there's tripoding. We can see some retractions there in his intercostal spaces. You can see up by his collarbones. Part of that's his positioning, but it does look like some good retractions there. It looks like he's a little bit diaphoretic there. And then we can like look at his skin. You can see parts of his skin. Now, I don't know how long he's been on oxygen here. And so I'm sure a lot of his color is coming back once he gets on oxygen. Right. But we can see that his color and some spots on his body, especially centrally there, a little bit on his face, it looks thin. The color looks thin. It doesn't look as full and as healthy as it might be. Now, obviously, we don't know this person, so that's just a guess. We don't have somebody to talk to or to say, hey, is this his? Does he look normal? Does like the tone of his skin look normal? Is that what it normally looks like for him? We don't have that person here, so this is obviously just a guess, but he's showing some real obvious signs there of trouble breathing. And if this were our patient and we walked into his home like this, right when we get in the door, before we even get to him, if we look at this person here, we can take on a whole bunch of clues. And, as we're walking across the room to go introduce ourselves to them, like this is trouble breathing. I already know. Let's get the SpO2 on. Let's get the oxygen ready, and then let's dig in and fight this. So I'm already, before I even get to him and introduce myself or say anything to him yet, I've already got an idea of where my treatment path plan is heading there just by looking at this. I think this is a great picture for that, displaying that. More observations for difficulty breathing. We've talked about the noises the last couple of days. So normal breathing is quiet breathing. And so if you can hear somebody breathing, there's an issue. It's at least starting. It's at least an issue starting. Maybe it's already progressed and it's really bad. But if you can hear somebody breathing, it's not normal. It's not normal. So we should take that as a clear and obvious sign that something is going on. Most of these noises that we're going to hear, it's caused by obstructions somewhere in the airway. So if we're hearing these noises, it's either the closing up of an airway, the constriction of an airway, or something is in the airway obstructing it, whether it be a foreign body like food or toys or coin, whatever it might be, things that kids swallow, or it can be like mucus, thick mucousy secretions, or other fluids like in the airways. Those could all be signs of obstructions. And so all of these noises that we're talking about here are reflective of that. And so if we hear these things, we can automatically say, okay, the airways being obstructed either by reducing tidal volume, constricting the airway, or something's in there. So all clear and obvious signs that there's something going on inside the body that's making the breathing difficult. So we know about these noises here. So we have audible wheezing. That's wheezing we can hear without a stethoscope. It's gurgling. It's indicative of fluid in the upper airway. Snoring, we know what that is. Stridor, it's a high pitch, almost kind of like a whistle. That is indicative of an upper airway obstruction, either by swelling or there's a foreign body in there. Coughing, I think we know about coughing there. And then as we talked about in class the last couple of days, we've got our rails and our rhonchi as well. those in. We know how to auscultate and know where um, as well. So auscultating, the wheezes, what we'll hear is it's high-pitched sounds created by air moving through those narrowed passageways. And so things like asthma can create that. Crackles, it's fine crackling or bubbling sound, kind of sounds like Rice Krispies. That cereal, that fine bubbling, cracking sound. And when you listen to it, once we listen to this a few times and we start to get it, you'll realize maybe you have already after we listen to it in class, but it sounds like that fluid's really thin in there and the air is just like bubbling through it, coming through where that air is in the alveoli and it's bubbling through or going one way or the other. But it sounds really thin and like water almost, right? It's not thick like rails or rhonchi are. Bronchi is those lower pitched, kind of heavier, thicker, fuller sounding, kind of snoring, rattling, kind of popping a little bit. These are thicker secretions, so mucousy secretions. They're usually found in the larger airway structures there, so the bronchi, things like that, not where we get down to those bronchioles. Now, they can get down there if it's been happening for a while, but usually it's secreted in the larger airways there. Stratter, we talked about high-pitched upper airway sound. It's always indicative of a partial airway obstruction. So whether it's swelling or a foreign body, it's that high-pitched sound right there. So when we have breathing difficulty, we have any kind of problem in the body, we're going to see changes in vital signs, right? This can show us how things are going, how the body's compensating, how it's meeting the challenge of this difficulty breathing. So we may see an increased or decreased pulse rate. If it's an adult, we'll see that increased pulse rate. To try for the compensation for the kids, we'll see the decreased pulse rate. We can see changes in the breathing rate, obviously. So if your tidal volume is going down, what do you think your breathing rate's going to do? If we're not breathing in as much air per breath, what do you think your breathing rate's going to do? It's going to go up. If each breath is only this much instead of this much, then we have to take more breaths to equal that out, right? So you'll be breathing faster, getting all that oxygen, trying to get that oxygen in. Hopefully the rhythm stays the same, but we can see breathing rhythm changes, and we'll get into a couple specific ones when we talk about diabetic emergencies and head traumas as well. Then we can see hyper or hypotension also. So again, it's part of the vital signs that we're aware of. We're expecting to see changes as things progress, as our treatment with the patient progresses. Hopefully things get better because of our treatment, but we can also see changes. We can see the trends because we're taking the vital signs multiple times with patients getting worse as well. So just keep an eye out for those things. Good observations to make with breathing difficulty. All right, patient care here. We always have to consider the two questions we always ask about every single patient, right? When we're in our ABCs. Are they breathing and is it adequate? So hopefully everybody's answer to question number one is yes, right? Hopefully that's the case, but unfortunately we know it won't be, but hopefully that's the case that they are breathing. But then the big question is where the critical thinking comes in is it adequate? So are you seeing signs of inadequacy? Is it short, choppy sentences when they're speaking? Is their color poor? Do they have an altered mental status? Are they diaphoretic? Are they working really hard to breathe to get that air in? Things like that. If you come to the conclusion that breathing is inadequate, not enough to sustain their life, then we have to ventilate, right? For what they're not bringing in enough, and supplemental oxygen probably isn't going to do it alone. If we've gotten to being inadequate, we're probably past the point where that supplemental oxygen can help by itself. So we're going to need to ventilate. So we need to know those. We need to know those rates, right? Once every 5 to 6 seconds for adults for 10 to 12 breaths per minute. Once every 3 to 5 seconds for kiddos for 12 to 20 breaths a minute. If the breathing is adequate, however, they're still showing signs and symptoms of breathing difficulty, dyspnea, then we can just apply Supplemental oxygen, either non-rebreather with 12 to 15 liters per minute for high flow oxygen, or the nasal cannula, 2 to 6 liters per minute for that low flow. Right, but the critical thinking part is right at the beginning. Are they breathing, and is it adequate? If you come to the conclusion based on your observations that it's inadequate, we need to hit them with the ventilations, along with that supplemental oxygen. If you think that their breathing is adequate, it's enough to keep them alive, then maybe we can just go to supplemental oxygen, just providing the oxygen for them. But be prepared to change your mind. Things can get better or things can get worse, right? Like, ah, man, you know what? They actually do need some ventilations here. So oxygen's not doing it. Okay, so change up your plan. That's fine. That's fine. As long as we can justify what we're doing, as we always say, that's good. You can make a decision and go with that as it is in the time, right? Maybe 10 minutes later, things have changed completely and your decision is no longer applicable, that first decision, and you have to change your mind and do something else. So be flexible. Always be flexible, okay? All right, for the patient care, placing them in a position of comfort. Most breathing difficulty patients are not going to like lying down. It's not comfortable. It makes it harder to breathe. So just placing somebody in a position of comfort can do a great deal to help them feel better. So sit them up, Fowlers or semi-Fowlers, when we put them in those positions. If it's asthma, then use their prescribed inhaler for them. Or maybe if we have ALS with us, maybe we can set up the CPAP to use that. And we've talked about CPAP. This is continuous positive airway pressure. It's a mask that gets strapped onto the face, strapped around the back. It's on there real tight, and it blows air continuously down the airway. So much so that the patient has to work hard, has to work harder to exhale to overcome the pressure of the CPAP, overcome that air blowing in. We have to blow harder to get the exhale out. This has it's got a lot of positive effects using the CPAP. It's a great tool to have to be able to use there. It can push fluid out of the alveoli into the interstitial spaces, things like that, get them out of the lungs so we can clear up some of those alveoli so we can have a proper gas exchange, right? CO2 coming out, O2 going in. It's great for pulmonary edema, right? The fluid shift into the lungs. Somebody that has just been pulled out of a pool for drowning or river, whatever it might be. Asthma, COPD. This is often used for COPD exacerbation patients when they're having a COPD emergency, when that situation gets bad for them, or just respiratory failure in general. But there are contraindications to this here. And a severe altered mental status is one. They have to know what's going on. They have to be able to keep this mask on. It's not comfortable. People get claustrophobic. It's like strapped tight to your head, so it's not going anywhere. It's not just kind of looped around the back of the ears, like the back of the head there, like a non-rebreather. It's really strapped on there to get a good seal. They also have to be breathing on their own. So if they don't have a normal, spontaneous respiratory rate, they're not breathing on their own, it's not going to work because they have to be able to exhale on their own. And not only do they have to be able to exhale, but they have to be able to exhale more powerfully than the air that's being pushed in, so they can push those waste products, that CO2 out there, right? They have to be able to sit up to do this. And as we know, ventilating a patient can cause hypotension. We can drop their blood pressure. And so if they're already hypotensive, or if they're in shock, which leads them to be they're hypotensive if they're in shock, we can't use it because we're just going to further lower their blood pressure, and that's going to put us in a worse spot, and put the patient in a worse spot. So make sure we know these contraindications. Nausea and vomiting also. Where's the vomit going to go? If they got this mask strapped to their head, where's that vomit going to go? It's got nowhere to go except back down. And because there's this continuous air being blown into their lungs, then it's going to go back out into their lungs. They're going to aspirate it. And it's terrible for everybody involved, right? That's basically, it means a pneumonia. If they live through it, they're also going to destroy a whole lot of their lung tissue. So, we're making things really bad if they aspirate stuff. So no nausea and vomiting, no chest trauma. They have to be able to use their chest wall, the muscles on the chest wall, to exhale. All right, they have to take that passive process and make it an active process and use the muscles to push the air out. So if there's chest trauma and they can't use their chest wall, CPAP is out. Shock, obviously, we already said that. Upper GI bleeding or recent gastric surgery, we don't want that. And any conditions that might prevent a good mask seal. So if they're um, if they're not hypotensive yet, they look like they're going into shock. Something, maybe you can say they're not there yet. They might be really, really sweaty. Maybe there's an injury to the face or something like that that prevents it. So if we can't get a good seal, it's not going to work well. Side effects of this, we talked about the hypotension. You can actually pop somebody's lung here to get, so you get the pneumothorax. We just have to put it on very lower pressure. We can't blast somebody with it, but that's going to be the medic's decision, not yours, and how to run it. So as the EMT, you can help set it up. Obviously, there's an increased risk of aspiration of anything. It could be saliva or something like that, spit, right? But if they did vomit into the airway, then again, where is it going to go except blown right back into their lungs? So obviously there's an increased risk there. And then drying of corneas, that's because the mask is sitting there and we can have some air blowing up into their eyes there as well. Obviously, when we're putting on, we're going to explain it to the patient just as we do everything else. And then we start with a lower level to see how things are. That's the medic will do that. And then they'll turn it up a bit to see how the patient's handling it, if we're getting good results from it. Here's our favorite guy, respiratory distress grandpa. He's in every EMS book ever. Never ends up well for him, though. All right, when we use CPAP, we got to reassess patients' mental status, vital signs, and dyspnea levels frequently. How do they feel about their breathing? Is it still difficult? So it's a continuous reevaluation once we're putting this treatment on the patient. It's a continuous reevaluation there. We all saw Forrest Bates guy, right? The hypoxia video. How long did it take until once he started getting oxygen, until we started getting like good mental status stuff? It wasn't very long. So hopefully after we get CPAP on here, if their lungs are full of junk, full of fluid, and we blow some of that stuff out, clear out some of the alveoli so the oxygen can access that, hopefully we're going to start seeing some signs pretty quickly. Status changes for the mental status changes. Maybe skin starts looking better. You can put this thing on and have somebody that looks gray. You can see the color just come back to them. And so we got to check in frequently with how they're doing. All right, here's the CPAP setup there. We see how it's strapped to the head, how it's really strapped on there. So imagine if respiratory distress grandpa here, if he vomits right now, where is that going to go? Right? It's going to get forced back down into his lungs. That's real bad. So he's on there, he's taking it, still a little tripoding a little bit. And we see our hero here, the EMT, she's taking vital signs to reassess respiratory distress grandpa. If we don't see positive changes and things, what's going to happen is the CPAP is going to come off, and then we're just going to go to ventilating with the bag valve mask at that point. See, I told you, never ends well for respiratory distress grandma or grandpa. Whatever EMT medic textbook that you're looking in, this guy shows up, but it never ends up well. Never ends up well. All right, let's talk about some certain respiratory conditions that we should be familiar with out in the field. All right, first thing we're going to talk about is COPD. COPD is a blanket term. It's an umbrella term for a number of diseases that fit underneath it, and they're classified as COPD. The two that we're going to concern ourselves with are emphysema and chronic bronchitis. There's many others. COPD, chronic obstructive pulmonary disease. The vast majority of people that get this are smokers. the overwhelming majority of people that get this are smokers. So you are going to see this out there. So let's talk about chronic bronchitis. Much like bronchitis, your bronchial lining becomes inflamed, except you basically have bronchitis all the time. So with the lining becoming inflamed, it swells a little bit. So with that swelling, it starts to restrict the airway because of the inflammation there. So the airway, we're losing a little bit of tidal volume there. And then we're producing excess mucus, which is gets down in the lungs. And so that mucus is taking up space that air could be going. So again, we're losing more tidal volume. And then on top of that, there's these things called cilia. They sweep the mucus and things up and out of our lungs so we can cough things out. Well, those cells get destroyed over time by smoking. And so we can't clear the mucus as easily as possible. So not only are we losing tidal volume here, it just kind of gets bad. It gets worse, right? And it's hard to clear things out when especially around all that mucus. So when we have a bad case of this, somebody has bronchoconstriction going on for two reasons. It's the inflammation and the swelling and all that excess mucus in there as well. And that's just dropping the tidal volume on these people. So you'll see these folks. These are the folks that you see, at Walmart or wherever they are, carrying around an oxygen bottle. Uh, both of these diseases, anybody with COPD, a lot of times they'll have personal oxygen at home or they take it out with them, especially when it gets bad. We'll come back to this picture in a second. Emphysema, the alveoli walls, they actually break down a little bit. And so what happens is they lose surface area. And if these alveoli lose surface area, there's less places for the capillaries, the pulmonary capillaries to surround the alveoli. And so we don't have as much of an opportunity for the gas exchange. There's less places for the oxygen to jump in and the carbon dioxide to jump out. And so we're getting less oxygen on board. We're getting less carbon dioxide off board, right? The lungs lose elasticity. They're kind of stretchy, right? They're not these really rigid things. They have to be to expand and contract and all that there. So they lose their elasticity. And so what that means is that you can't take a really full, deep breath. Your lungs just don't expand like they used to. They're more rigid than they were. All this results in air trapping. So air, the waste product carbon dioxide gets trapped down there. And so we're reducing the effectiveness of normal breathing. A lot of times when you see air trapping happening, the patient, when it's bad, the patient has to cough to force out the air in order to kind of clear that out to bring in a fresh breath. So you'll see that. We saw that in our anaphylaxis video where that woman gave herself her EpiPen there. You could hear her coughing on each and every exhale. And that was one of the reasons here is because she was air trapping. So you'll see that with emphysema as well. Let's talk about those walls breaking down again and go back to that picture. If we look on the left, that's normal, right? And it's your normal alveoli there. In the middle with chronic bronchitis there, we'll get to that in a second, but let's talk about the decreased surface area that emphysema causes. That's going to be the picture on the right. If you can see there, those dotted lines, they represent where those walls used to be. Compare the picture all the way on the right to either of the other two, and you'll see that we're losing those little spaces there for the alveoli to surround, for the capillaries rather, to surround the alveoli. So there's less places for that gas exchange to happen. There. So that's a good representation of that there. In the middle, we see chronic bronchitis. I wish they used a different color for that. Hold on, let me see if I can do this. Can I change colors? What is that? Never mind. I was going to draw on here a little bit, but we'll use that. All right, so we can see and hear all this mucus, thick mucus, and you can see it's blocking up um, those the entrances into the alveolar sacs there. So that's going to prevent air from going through. When the air does go through there, you're going to hear things like um, bronchi and rales and stuff. It's the air passing through all that stuff, but it's taking up a lot of room that could be taken up by air and an otherwise healthy alveoli there. So you can see how we can block things up, how the noises can get made with air passing by that and through that there, and then how you can see that we're getting less tidal volume as well. Mm. All right. So that's COPD. Those are the two ones that we'll talk about in COPD, chronic bronchitis and emphysema. Let's see. Going the wrong way. All right. So about asthma, we know about this. We've talked about this a bunch. It's a chronic disease. It's usually somebody, if you got asthma, you usually got it. Now there's cases where you get it as a kid and you grow out of it, things like that, or you get it later in life. You develop it sometimes, but you have it's episodic, so it's once in a while it happens. It can be as a result of cold weather, cold air, breathing in cold air. It can be exercise induced, things like that. During when it's happening, the bronchioles they narrow. So there's bronchoconstriction happening there. At the same time, we're overproducing mucus. And so, just like chronic bronchitis, with the overproduction of mucus, we're losing a little bit of tidal volume. And then with the bronchoconstriction, that's where we get the vast majority of our loss of tidal volume because those airways are just so small now. Those airways being small and the air going through them produces that wheezing sound that we're going to hear. Now, this can be deadly. You can die from an unchecked asthma attack if you have one that's bad enough. If your bronchoconstriction is bad enough, it can definitely kill your patient. So it can be a life-threatening disease there. So again, asthma, we know there's bronchoconstriction. They shut down. That's the big thing. And then there's also that excess mucus in there as well. Normally, we're going to hear the wheezing on exhales. And so that means that the air traveling is restricted in the one direction. In the actual process of inhaling, the diameter of our airways can open up a little bit. Now, it can get so bad that you can hear inspiratory and expiratory wheezing as well. But what you're normally going to hear it there, in cases that aren't severe, is just on expiratory wheezing. All right, pulmonary edema. We've talked about that. It's an unusual amount of fluid that is accumulated in the lungs. It is a lot of the time. The patients that we're going to see that have pulmonary edema, it's a result of their congestive heart failure. We've talked about that a little bit, and we're going to learn about it in our cardiac emergencies even more in depth there. So as we know, basically the blood gets backed up in the system, pressure builds, water and other fluids escape there and go into the interstitial tissues, and gravity brings it down into the legs and into the hands there. But when it's in the lungs and it's getting pushed out of the lungs, that fluid accumulates in there. Obviously, that fluid's taking up space, so your tidal volume goes down, things like that. Makes it more difficult to breathe. And that fluid, this is going to be like a thinner fluid. This is where we're going to get the crackles and the rales from when we're auscultating those sounds there, that snap, crackle, pop there. So with pulmonary edema, as we said, with congestive heart failure, the pressure builds up because of that traffic jam of the blood flow. It builds up in those capillaries there, and it pushes the fluid across the barriers into the alveoli. right? That's where their alveoli, the sacs, are right up against all those capillaries, and so those capillaries, they leak out and it goes right into the alveoli there. So all of that fluid, it's taking up the space and kind of like the lower airways. It's in the alveoli, things like that. That air passing through it and by it, and that's where we get the snap, crackle, and pops. That produces obviously lower tidal volume for them, which then gives them dyspnea, the trouble breathing and difficulty breathing. Common signs of this are trouble breathing, the dyspnea, the difficulty breathing. When people have difficulty breathing, if you've ever had difficulty breathing, a certain level of anxiety accompanies that, especially if it's serious. So expect them to be anxious. They'll be pale because of a lack of oxygen. They're probably going to be sweaty because they're going to be breathing a little bit harder. They'll be tachycardic because they're trying to push that blood around as fast as possible to pick up whatever oxygen it can, right? One of the compensation mechanisms. But we're also going to see it as a sign of this hypertension. So when you're taking vitals and you're checking your patient out there, if they're tachycardic and they're hypertensive and they're having this dyspnea, that should be those three things together. That should be kind of a pattern recognition thing for your attendant to go up and be like, okay, are we dealing with, is this a breathing problem because of a cardiac problem? There. Now, we can't fix the cardiac problem, but we can help with the breathing problem, but that can lead us to what is going on here. Again, the respirations will be rapid, right? Compensation, they're not breathing well, so the body's going to want to breathe faster, and they're going to be working hard for this. And because of the loss of tidal volume here, and the blood basically not flowing as freely as it was, we're going to get low oxygen saturation here. So we'll get low O2 sats. When it's really bad and patients are full, like you can just hear it in all fields, right? You're listening mid-clavicular, mid-axillary, and in the back there, right? Top, middle, bottom of the lungs, we're going to be hearing this stuff all over. And when they're really full like that, in really bad cases, it might be coming up into the airway. So you might be hearing a little bit of gurgling sounds there, but we're definitely going to be getting the crackles. It may be loud enough where we're hearing it audibly. I mean, it's like without auscultating, without our stethoscope. They can also cough up this fluid too, and it's called sputum. It's basically like spit. It's going to have tons of bubbles in there because of how it's bubbling basically in the lungs. It'll have tons and tons of bubbles in it. It's usually white, but if it's tinged with a pink color, then that means there's blood in there. And so that's an important finding to pass on there, that they did have bloody sputum. All right, for these folks, with these folks, we're probably, hopefully, if you're riding with ALS there, if you've got a mixed unit, probably going to go to CPAP for this. But in order to get there, we got to assess for their breathing, right? Are they breathing and is it adequate? So we got to make that decision about the adequacy of their breathing. And if it's inadequate, we have to treat it. So if it's inadequate, we're giving ventilations. So you have to decide here, is BVM going to be better for this patient, or is the CPAP going to be better for that? We're going to give them high flow oxygen, right? Lots and lots of oxygen, as much as we can there. And then one thing that we can help is their positioning, right? If we're doing CPAP, they're already sitting up. If they're a trouble breathing patient anyway, so they're going to be sitting up. But what we can help do is put their legs, instead of having them lay straight out on the cot, put their legs down off to the sides of the cot. That'll help any of those fluids that are getting pushed out of the lungs, right? Gravity's going to take them down and all that kind of stuff. At least we can still get it down into their legs. We're going to use those legs basically in transport as storage space for some of that extra fluid. So keep those patients' legs down there in that dependent position, the gravity dependent position where gravity will bring that fluid down. Right? So this is a simple question. Do you think somebody can have multiple respiratory disorders? Sure. Could somebody have pulmonary edema and COPD? Yeah, definitely. Do smokers have heart attacks? Yeah. Do they survive them? Yeah. Does that weakness in the heart sometimes lead to congestive heart failure? Absolutely. So COPDers can definitely have CHF as well, pulmonary edema, things like that. Of course, somebody can have multiple respiratory problems. Do you think anybody with asthma is also severely allergic to anything? Totally, right? So somebody can have asthma and allergic, severe allergy to something as well. Obviously, that's breathing can be a breathing problem. So of course they can. All right, moving on here. Pneumonia. It's an infection. It's a viral bacterial infection in one or both of the lungs. It can also be caused by fungi. Good times. Um, Basically you're inhaling whatever it is. So you've inhaled something, that virus, that bacteria that's floating in the air, you inhaled it, it settled down in your lungs and took root there and formed an infection. Causes inflammation. There's It's not pleasant for sure, especially when it moves to both lungs and you're dealing with that in both lungs. Not as bad in a singular lung, still bad. Signs of this: shortness of breath could be at any point. They don't have to be exerting themselves, doing something physical to get short of breath. They can just be sitting there and be short of breath. There's lots of coughing. There's Usually with infections of this type, we're going to get fevers and chills. Um, I have had it before. One of the times that I had it, I was living in South Carolina. It was the middle of the summertime, and I was sitting outside shivering, and it was like 95-degree heat. I was sitting outside shivering. My fever and stuff was so bad. I didn't know any better at that time. I was felt so cold and I had severe chills. I was like, I gotta warm up there. They can also have chest pains with this, and it can be sharp pain or pleuritic pain. That means like it's the we're pleuritic pains means lung pain, right? So this isn't going to be pain of a cardiac nature. If somebody had pneumonia, we're not going to be like, oh, do you have? They're having the chest pain. Once we figure out that it's not cardiac, there, hopefully we'll do that soon. But we won't be giving like this patient aspirin or nitroglycerin if they happen to be prescribed it. This is a different pain. It's lung pain versus cardiac pain. And it gets worse. This pain, again, it can be sharp. It can be bad on when they inhale, right? When they're moving those lungs greatly, using the muscles and everything. So it can be worse when they inhale. Other signs, symptoms, they can be pale, diaphoretic. You get really tired. With the fever, like high fevers that can accompany this. I mean, obviously that can lead to some confusion. I don't know if you've ever had a really bad fever, but sometimes you can just be out of it because of it. And also headache there. The treatment for this, it's mostly, as it says, it's just going to be supportive. So again, are they breathing? Is it adequate? So if it's inadequate, we can ventilate. We'll probably be giving some supplemental oxygen here too. In our system around here, we can't, as we've talked about, use CPAP. We can set it up. We can put the patient on it, but it's got to be an ALS provider that runs it. Luckily, most places around here, they ride on mixed ambulance, so you'll have an ALS provider with a BLS provider. These are patients that are going to need the oxygen, as we talked about, so don't withhold it from them. They can definitely get hypoxic from this. Just keep an eye out for all those things. This is something that needs definitive care, so they need medications that we don't have to be able to beat the bacteria or the virus. So they'll get that at the hospital for those things. So it's supportive care in transport for them. Again, just think about it. Just because it's pneumonia, it's really not that difficulty of a treatment procedure because we're treating them almost like any other breathing patient. We're making sure they're breathing well on their own, that they're ventilating themselves well on their own. And if they're low on oxygen, if they feel like they're having trouble breathing, then we'll give them oxygen. Basically, it's your basic treatment for breathing folks, or trouble breathing folks, that is. All right, let's talk about spontaneous pneumothorax there. Um, it's a lung collapse, just kind of out of nowhere. It's spontaneous. Um, there's a population of folks that are more susceptible to this for whatever reason. So people with COPD, history of smoking, they're at the highest risk of this. And then for some reason, and I don't know what the reasoning behind this is, it would be interesting to find out, but tall and thin people. So if you're a tall, thin smoker um, with COPD, then you've got a pretty good, better chance than others at getting a spontaneous pneumothorax. Now, signs and symptoms for this: if your lung pops, guess what? It hurts. So you're going to get sharp pleuritic chest pain. Again, pleuritic means it's having to do with the lungs, so it's lung pain. You're immediately going to be short of breath. You're going to be immediately tired, very easily tired, because you're not bringing in as much oxygen. So you're going to have low energy levels. Your body, the cells aren't making as much energy to do the jobs they need to do. So you get tired, right? We'll have low oxygen sats, cyanosis. We'll start seeing that bluish gray color come in. Um, the body's going to be compensating, right? So we're not getting as much oxygen in. So what happens to the heart rate? Goes up. So we'll get tachycardia. The body's not getting as much oxygen in, right? Or it's bringing in the same amount. It's just some of it's going into your chest cavity here, that pleuritic space. And so you're going to be, your body's not getting that oxygen in past the chemoreceptors, things like that. And so we're going to say, all right, faster breathing, faster breathing. So another compensation method there. At first, we're going to have decreased lung sounds on the side where that that spontaneous pneumothorax occurred. That's going to be decreased until it's absent. Right? Once it collapses, then those breath sounds will be absent on that side. As it gets worse, because of the pressure that is building inside the chest, it puts pressure on the superior and inferior vena cava. But in this case, the superior vena cava, and so the blood starts backing up because that blood vessel is kind of being squeezed by the pressure. So not as much blood is getting back to the heart. So cardiac output is down a little bit. But we're going to start seeing signs of that with JVD, right? The blood's backing up in that superior vena cava. So that means it's backing up in all the places that dump into the superior vena cava. And so we're going to start seeing that JVD. We're also going to see, because of this, right, the decreased cardiac output, because of this, we're going to see a drop in blood pressure. So we can see hypotension from this as well. Treatment for this, we need ALS for this. So get them on the horn immediately, either rendezvous on scene with them or en route to the hospital. But if it's going to take too long, obviously, like we talked about, if it's going to take too long to meet up with them, then you might have to make the decision, well, we're just going to the hospital. So whatever works best, either get them to the scene, meet them en route to the hospital so they can jump on board your ambulance, or you can transfer the patient to theirs, or just get to the hospital. It all depends on where you're at, how close you're to the hospital. CPAP here is contraindicated. Obviously, if we've got air just blowing straight down into their airway continuously, well, it's going to go out that hole in the lung where it just popped, right? And so it's just going to fill up the space in the chest cavity even faster. So it's literally going to make the problem worse. So no CPAP for these patients. Get them to the hospital as quickly as possible there. And again, we may need that ALS help because they might be able to do chest decompression, thoracotomy to decompress the chest, ALS skills. So get them to the hospital or rendezvous with that ALS crew as quickly as possible. All right, pulmonary embolism. Let's talk about that. There is a blockage in the blood supply to the lungs, right? So somewhere between the heart and the lungs, before the blood starts making its return to the heart, there's a blockage somewhere. That blood's not getting by a clot. It's typically caused by deep vein thrombosis. Right? That's basically a clot, blood clot that's forming deep within your legs there, and then it lets go at some point, travels around through the body. gets up, comes back to the heart, gets pumped out to the lungs, right? And then as those blood vessels are getting smaller in the lungs, as it goes from an artery to arterioles to the capillaries in there, it gets stuck in one of those smaller things. Um, and so it's blocking the blood supply in the lungs. There. Common reasons how to get a DVT. Laying down or sitting down for a long time, you're putting pressure on those muscles and the blood vessels in there. And so if you sit down for a really long time, like if you're on a intercontinental flight, you're flying to like Europe or Asia or something like that. You're just sitting there for a really long period of time. The blood can maybe get pinched off, start to pool in places because you're putting pressure on as you're sitting, and then forms that clot. And then when you get up and start moving around, it breaks off and gets thrown somewhere in the body. If you have active cancer, this can happen. If you're having a limb immobilized in a cast, right? We're not moving it, we're not doing things. Um, Signs and symptoms of a pulmonary embolism. All right, you get sharp chest pain again, but again, it's lung pain. It's not cardiac pain. They will feel short of breath, right? The blood is not getting to the capillaries, so the gas exchange is not taking place, and so we're not getting as much oxygen into the body. As soon as that happens, we start to feel short of breath. So these people are feeling short of breath. They're going to be anxious again. Breathing problems bring on anxiety. They'll be they're going to be coughing. They'll have tachycardia. They'll have tachypnea as well. So really high heart rate, really fast breathing. They're not bringing in as much oxygen, and so we're going to get lightheaded and dizziness. We can get altered mental statuses here. Pain or swelling in both legs. That'd be a sign of like, oh, there was a pulmonary embolism here, so there it's probably happening here. So maybe that's what the cause is over here in the lungs. Hypotension, cardiac arrest, all these things can happen. This is hard to see in the field, right? It's sometimes this can be a tough one if you don't have these obvious signs like the chest pain, feeling short of breath, things like that. Maybe it doesn't happen for very long. If it's a large blockage, maybe it doesn't happen for very long. And by the time you get there, you have a person that's unconscious, that's unresponsive there. And the bystanders may have said, oh, she said she had a really sharp chest pain and that she couldn't breathe. And a few minutes later, she's panicking, and then she starts to act weird, and now she's unconscious, right? Maybe they can show that decline there to you in their reporting of the story. But sometimes it can be difficult to see. You're going to look at them, and they're going to be like, your work of breathing is good. Like, I don't see any problems there. Air is moving in and out, right? There's no problems with the airway. So you're going to have clear lung sounds. Work of breathing is going to look good, right? They're going to eventually start breathing faster and faster. It's going to be, man, why are you feeling short of breath? Well, this could be it. So if you have these kind of symptoms there, some pleuritic chest pain, sharp pleuritic chest pain, trouble breathing, but work of breathing looks good, airway looks good, nice and clear, maybe you have to consider this and ask some questions like, before this happened, were you sitting for a long time? Did you take a flight? Were you on a road trip in a car for hours on end? Like, try to dig into this, do a little bit of detective work there. But the treatment for this is in the hospital. It's definitive care. So again, let's treat them like a trouble breathing patient. Administer high flow oxygen to them, ventilate if necessary, get them to the hospital. Pretty simple. Epiglottitis. This is an infection of the epiglottis, and it causes a swelling of the epiglottis and around it. As we know, the epiglottis is that leaf-like structure that closes over the airway every time we swallow, right? And so if this gets swollen, right, and inflamed, in really bad cases, it can just block off. It can swell enough where it blocks off the airway. So pretty bad, right? It could be a life threat there. Signs and symptoms of this. So it's going to be a sore throat, right? We have pain and swelling in here. So you're going to get the sore throat. They're going to have trouble breathing because of the obstruction. So They could be tripoding, right? We can see that positioning there. They're going to look sick. It's an infection, right? So, like other infections, they could have a fever. With that, um, they're just going to look sick. Um, it's going to be hard for them to be moving air past this, so it might be with the inflammation there. So they might have a little bit of a muffled voice. Um, these folks can be drooling because it's going to be painful to swallow, right? If the epiglottis, that every time you swallow, does this movement and it's all inflamed and swollen, well, it's going to hurt to move that every time. So they're not going to want to swallow. So that's why they could be drooling there. And because this is an upper airway obstruction, all this swelling and inflammation here, we can get stridor out of this. Remember, that's that high-pitched whistling sound that we can hear, and it's indicative of upper airway obstructions, whether it's foreign body, swelling, inflammation, whatever it might be. It's upper airway obstruction there. The patient treatment for this, it's pretty simple. We just want to keep them calm. Don't stick anything in their throat, right? Just keep them calm. Let them, if they need to kind of sit forward a little bit, they're going to be sitting up, Fowlers, semi-Fowlers, and they may need to put their feet down to kind of try to tripod a little bit there. Just try to keep them calm. We don't want them getting like too excited or yelling or doing anything that could worsen that inflammation, right? So just keep them nice and calm. We don't want that airway to suddenly close off, is what I'm saying. So keep them calm. Don't stick anything in the throat. Don't ask them to open up and say anything like that, right? Give them high flow oxygen if possible. If they're comfortable wearing the mask there, if they're not good with wearing the non-rebreather, maybe have them hold it right next to their face. Do a little bit of a blow by there. Give them as much oxygen as possible, and then get them to the hospital. Croup. This is a respiratory illness. A lot of times you're going to see this in kids. You get inflammation of the larynx, the trachea, and bronchi there. So you get that infection. Tissues in the airway, they're going to swell, and that swelling reduces tidal volume, so it's going to restrict how much air can go through there. Croup patients have a very distinctive cough. It's a loud seal-like cough. It's like a seal barking. It's not seal-like cough. It's like a seal bark, how a seal barks there. They'll have a hoarse voice as well because the vocal cords can be inflamed. Anytime you have that hoarse voice, it's your vocal cords get inflamed there. So it says here, I don't know why they put it like this. Associated breathing difficulty typically resolves when the child moves to an upright position. All right. Trouble breathing patients don't like laying down. It makes them feel better sitting up or tripoding. That's all that's saying. We can see signs of hypoxia because of this, because of the loss of tidal volume, because of the swelling. So that means we can get all the usual signs: cyanosis, altered mental status, paleness, diaphoresis, all the other signs of difficulty breathing and body compensating, right? Faster breathing, higher heart rate, all the rest of it. We can have stridor there as well. Again, if signs, like every other patient, if there are signs of inadequate breathing, then provide ventilations and transport. Obviously, transport quickly in all of these situations, because that is a true emergency when we're breathing for somebody. All right, got to get them to definitive care. So if they're in respiratory distress, these patients, and they're breathing adequately, just transport them. See if we can rendezvous with ALS. The reason is if we start to get that airway swelling all the way through and it could close off, then maybe ALS can get a tube down, it can intubate them, get an ET tube down there prior to that happening. Give them oxygen, obviously, if they're hypoxic, just as we do with anybody else, and just keep them in a position of comfort, right? Again, kind of keep them calm, easy, relaxed, things like that. We don't want that airway closing up. All right, bronchiolitis. These are small bronchioles, like bronchitis. Um, they become swollen and inflamed there, so it's a viral infection there that you'll get. It looks like a cold, runny nose, fever, general illness kind of things. It usually takes several days to get into where it could be an emergency, where they move into respiratory distress and they're actually having that trouble breathing. It's easily transferable, so you'll have it's easy for this virus to be passed on. So you'll oftentimes have multiple people in a household that may have this. And as it gets worse over several days, it can go from feeling bad to respiratory distress to inadequacy in breathing. So it can just get worse there, right? Again, any other trouble breathing patient, if the ventilations aren't adequate, we ventilate. And then we give supplemental oxygen here. If they're hypoxic, they show signs of hypoxia. We have a low SpO2, right? Anything below 95 is hypoxic. Um, for kids, if they're especially younger kids who are more dependent on nose breathing, we can take a bulb syringe and suck out the mucus if it's developed into their nose. They got the really bad runny nose. Um, uh, like I said, especially for those infants, it can be much better for them breathing through the nose if we clear that out, right? Infants in particular, they're nose breathers, obligate nose breathers, which means they don't really know how to breathe out of their mouth. So if we clear that with the bulb syringe, the snot in their nose, it'll improve their situation greatly. Cystic fibrosis, it's a genetic disease. Basically, you're born with it, and it appears at some point in childhood. What this is, it's a respiratory illness. We get thick, like really thick, sticky, mucousy stuff that builds up and accumulates in the lungs and the digestive system there as well. Um, but it causes, like, they can't clear it. It's so thick, it's hard for them to get it out, and it can cause infections down in the lungs, which is where we're going to come in with our trouble breathing treatments here. But it can also cause real digestive problems too in there. So, signs and symptoms, they'll be coughing a lot, trying to clear this thick mucus out. So there'll be lots of mucus in there. They'll be tired because they're not bringing in as much air, right? Lots of thick mucus in the lungs. We have less tidal volume, less places available for oxygen to participate in the gas exchange. Because they have all this stuff down there, they get pneumonia a lot. These people go to the hospital for breathing problems a lot. Even if it's well managed, it's not uncommon for people, where everything's right. They live in a good space. It's clean. It's like not too moist. Things like that, where they can protect basically their lungs from what they're breathing in. Right? They're not living in a household that's full of mold or things like that. Even if it's well maintained, it's not unusual for them to go to the hospital, once or twice a year at least for having an exacerbation here. It can also cause abdominal pain and distension because of all that excess mucus that's in there. They can cough up blood. They can be nauseous. They can have weight loss from all these things. It's not a good time. Not a good time for them at all. Now, this is not an uncommon disease, but it's not a common one either. We should know about it. We learn about it because it's out there, and we're going to run into people that have this. However, the best people that will know the ins and outs of this disease, how it feels, and what can work for them are the patient. And if it's a younger patient, their mom or dad, their caregivers, right? They're going to know, all right, what works here? Don't be afraid to ask. It's not, they've been to the hospital. They've been on ambulances before. They know the deal. They know that this isn't something that we're highly specialized in there. And so they will tell us. And a lot of times, if you get a patient like this who can talk to you, or a really good caregiver who's on top of things and can communicate these things with you. They'll give you all the information that you need to know. So don't be afraid to ask if you're unsure. Okay. As it says here, patients and the caregivers can often guide their treatment because they've done this before plenty of times, most likely. So don't be afraid to ask them. All right, so there's tons of viral respiratory infections, and it's an infection of the respiratory. In fact, uh, you know, common in adults, affecting more than 17 billion people each year. So, more than twice the population of humans on Earth. So this is basically saying everybody gets one twice a year on average or more. Right. So there's a lot. You can have them. You can go to the doctors. You get some antibiotics, things like that, or antiviral medication, not antibiotics, right, but antiviral medications there, and you'll be okay in a week. Right. It's common. We've probably all had one. It's your general sickness here. You get runny nose, sore throat, scratchy throat, coughing, fever, fatigue, chills, um, and it can spread into the lungs, or it can stay in your throat, things like that. But it can cause shortness of breath and breathing problems. Well, dyspnea. Cough can be consistent or persistent, as it says here. And oftentimes a good signifier of this is ask the patient what color their snot is. If it's like that neon yellow greenish there, that's usually a sign that your body is fighting something. So it's that bright yellow, greenish, neon kind of stuff, right? That they're coughing up, that they're bringing up, or that they're blowing out of their nose. Ask for both because it could be different colors. Uh, Ask what the color is. If it's that, it's likely they're dealing with an infection, a viral infection. For this, again, treatment's easy. Give them supplemental oxygen. Give them oxygen should they need it, if they're hypoxic, and if their ventilations are inadequate, give them ventilations. Pretty simple. So pretty simple. These are very common stuff. There. All right, so now we'll talk about real quick the prescribed inhaler and stuff. Again, we've gone over this. We did this in pharmacology, so we'll just touch on this. If you need to know any of the finer points, just go back to the chapter on that. So we'll talk about that here real quick. All right, the inhaler. It's also called a metered dose inhaler because it provides the exact dose of the medication. It's metered out. Each spray, squirt, or whatever of the inhaler there should be the same amount of medicine in each. Typically, as we know, it's prescribed for asthma or other conditions that cause bronchoconstriction. You know what it looks like. We know this is about the 5 rights and how to give it, and we've been taught that, so we know that. If you have any questions about the prescribed inhaler, please go back to the chapter 18 info. Here you can see it with a spacer. This makes, as we talked about, this makes the timing less critical because you have to inhale as soon as you squeeze that thing, and if you don't, all that medicine just ends up all over your mouth and on your tongue and stuff instead of going down into your lungs. So like this is used for like kids. You can squirt it into that little chamber there, and it'll just be kind of floating around in there, and then the patient can draw out of that to get their dose. That makes it easier. And we know how to administer it. Small volume nebulizer. This is going to be a medic level skill here in our area. What it is a device to give breathing treatments to people, and it's basically you have it's a little tiny cup that's filled with liquid medication, and you run oxygen through it, and the oxygen bubbles through and creates these vapors, and the patient breathes it through. And the patient is basically breathing in the medicine over several minutes as it's going through. It helps to give a it's rather than just two quick puffs for a dose. They're taking this and bringing this in over several minutes, and so it gives the opportunity for that medicine to get everywhere in the lungs to help out. So it's a very effective way of delivering medications down into the lungs. There. Here's a little picture of it. Got there's a little right here, right above the EMT's glove there. Let me see if I can. So right here above the glove is a little kind of cup there, and you hook the oxygen. You can see the tube coming up below it. Oxygen bubbles up through the cup, makes these vapors, right? And so the patient just kind of breathes through this tube and is breathing in the medication down into his lungs there. Again, real effective way of getting medications down there. Just like with the albuterol, anytime we were breathing this, you're going to take a deep breath in, try to hold it for a couple of seconds, and then breathe it out. So, if they can, try to have them breathe slowly and deeply through this. All right, and there you go. There's our chapter review. All right, so just be aware of the different rates that we talked about, the signs of adequacy versus inadequacy when it comes to breathing. What does it look like? What does it sound like? We should know what those sounds are. And those will all be up on our canvas. They're the lung sounds that we listen to in class. And then just realize a lot of the treatments that we're giving it's all based off of, do we need to give oxygen, and answering our two questions. Are they breathing, and is it adequate? And so, like we said, most of these conditions here are treated with just those things, answering those questions, and providing oxygen. So a lot of different things, lots of different causes, but a lot of the same treatments. So it kind of makes it easy for us as the provider. All right, that's all we got. If you have any questions, shoot me an email. Let me know. See you next time.